Thank you, Dr. Anjana. Next, we will have Professor Fanindranath Tota oration delivered by Dr. E.K. Ramdas. I would like to invite Dr. Anita Shenoy to the stage to introduce our esteemed orator, Dr. E.K. Ramdas.
I have the privilege and pleasure of introducing my dear colleague from years ago, Dr. Ramdas, for this very privileged position of being an orator for Professor Fanindranath Tota oration. Dr. E.K. Ramdas, he's the head of Department of Anaesthesia, Baby Memorial Hospital, Kozhikode, Kerala. Yes, I can say Kozhikode. He is accomplished and experienced anesthesiologist with over 40 years of expertise in various domains of anesthesia, including pediatric, urology, and renal transplant anesthesia. He is currently leading the Department of Anesthesia's Baby Memorial Hospital, as I already told you. It's an 800-bedded ISO and NABH accredited multi-specialty teaching hospital. He has demonstrated leadership in professional societies with a strong record in academia and clinical research. He oversees clinical operations, quality improvement, departmental administration. He is also chairman of the blood bank committee there. So he has been the head of the Department of Anesthesia, National Hospital, Kozhikode, Kerala, 1998 to 2000. Then he was assistant professor in Kerala Medical College from 94 to 98. Assistant surgeon 1982 to 94. So that goes backwards. Right. He has a DNB, MD in anesthesia from us. He also had diploma in anesthesiology from BJ Medical College, Ahmedabad. And his MBBS was from JNMC, Belgaum. Right. His interests are pediatric anesthesia, urology and transplant anesthesia, pain and palliative care. He is affiliated to many professional societies, like many of us. Also regular faculty at Kerala and National CME, so we keep meeting. But above all, as I said, he was a dear colleague. I still remember very quiet, but very efficient and dignified, as you can see, a colleague, very reliable anesthetist. He was also popular, and I still remember your thesis. Dr. E.K. Ramdas, my pleasure to present to you all.
Thank you all. Good morning to everyone. Respected senior faculty members and dear friends and students. Actually honored by this invitation to present this oration, Fanindranath Tota oration, dedicated to my beloved teacher, Dr. Fanindranath Tota, who guided me during my days here in Kasturba Medical College and still guides me in my profession. And his wisdom guides me in my profession now. So, when Dr. Sweda, if I'm not mistaken, called to invite me for this oration, I was genuinely surprised. Am I getting a prank call? Then Dr. Krishna reached out. Then I really understood it's a real call. And of course, Krishna, I see him in almost all CMEs, and he reminds me of Dr. Fanindranath Tota. So Dr. Fanindranath Tota, he was my teacher. I was close to him as a student. I liked him so much. He was a guide, literally, for my thesis, and also as a source of inspiration. When I finished my thesis, I gave back to him for correction. He didn't like it. He gave it back to me and asked me to rewrite it. I didn't know what to do those days. There were no Googles, internet, nothing. So I was thinking what to do. Then next day he gave me a cassette and told me, you listen to this cassette and rewrite the CME, the thesis. And I was surprised. I took that cassette back home, and my wife knew typing. On a typewriter, she typed it and gave it back to me. And I was just thinking, who will go that far for a student? That was he, Dr. Fanindranath Tota. He had come to my house once, and we had traveled together to see a friend of ours. And that moment, I can never forget those moments. He may be gone, but he will never be forgotten. Now coming to the subject, this is a topic I have chosen for today. This is something which is dear to all of us. That is the reason I took it. We all know that safety is extremely important for us as anesthetist. And we also know that surgery would never have developed without anesthesia. But it's more important to know that anesthesia has absolutely no therapeutic benefit. It only is an adjunct to surgery. And therefore, whatever we do in the operation room for the patient should be as risk-free as possible. That is one thing we have to make it very, very clear. So I shall explain this topic, patient safety, under the following bullet marks. I shall start off with introduction with some historical aspects about the evolution of safety in anesthesia, then go on to theory of human error, risk analysis, risk-benefit ratio in decision making, and how to close the loop, and then finally surgeon-anesthesiologist relationship. Now to start off, I shall go back in history. Here you can see a very familiar picture. I'm sure you have seen it. The surgeon is Dr. Warren, patient is W.T.G. Morton, and the patient is Abbott. This took place in 1846, public demonstration of ether anesthesia. This event marked the long-standing focus on safety in anesthesia. And in 1848, there was discussions about death of a child, 15-year-old Hannah, and there was reports on morbidity and mortality in obstetric anesthesia published in the Journal of Anesthesia and Analgesia around that time. And over the next 60 years, reports on anesthesia-related mortality appeared in various journals. So, in addition, the ASA has focused on patient safety from the very inception of ASA. ASA started in 1905. From that day itself, we were very crucial about safety in anesthesia. The motto of ASA is vigilance. It reflects the long-standing emphasis on patient safety. Now, I've taken a sentence from one of Dr. Fanindranath Toda's lecture, which he made in 1991, where he talked about vigilance, the monitoring anesthesia, where he said, if I were asked to identify the single most important activity of the anesthesiologist, I would unhesitatingly choose vigilance. So our presence in the operation room is very crucial. We need to monitor our patients' vital signs. We need to monitor the potential complications that could occur during anesthesia. We need to monitor the progress of the surgery. So our presence should be in the operation theatre. That is very, very important. And this statement of Dr. Fanindranath Toda perfectly captures the essence of the duty we do in the operation theatre. A study published in the Annals of Surgery in 1954, long back, by Beecher and Todd, reviewed deaths associated with anesthesia and surgery. And these authors, they said that anesthesia is only an adjunct to the care of the patient, and this is not of itself of any therapeutic benefit. They noted that surgical patients have a mortality of 1 in 75, 1 in 95 chances of dying because of the underlying disease, and 1 anesthetic death in around 1,500 patients. So this was the estimate those days. but it would be the anesthetic incidence, deaths should maybe around 1 lakh to 1 in 4 lakhs now. They also called for viewing anesthesia as a major public health problem. So from that day itself, anesthesia was after safety. One of the principal accomplishments of this survey is to show the extent of our responsibility in the total care of the patient. This ignited further efforts to enhance patient safety. Now moving on to 70s and 80s, there were significant advancements in anesthesia, innovations, both in surgery and anesthesia. There were numerous disruptive technologies in monitoring and anesthetic medications like end-tidal carbon dioxide and pulse oximetry. Training in anesthesia intensified during this period. Hours spent in the intensive care units also increased. And in 1982, there were 3 separate incidences which ignited or galvanized the formation of the foundation safety in anesthesia. And those 3 incidences were, number 1, the power of the press; number 2, the liability insurance crisis; and number 3 was the desire of the American Society of Anesthesiologists concerned about safety. On April 1982, there was a documentary which was aired in the ABC, and the title of the documentary was "The Deep Sleep. 6,000 will die or suffer brain damage." This raised awareness among the general public about the safety, about the risk of anesthesia. This showed real pictures of the patient's relatives and said 6,000 will die in each year, and unreported cases of muscle paralysis would happen, cardiac arrest would happen, and then this was a major event and produced a storm or a tsunami among the people of that time in the US. And secondly, the liability insurance and the malpractice claim was so high that the anesthesiologists were not either able to pay it or it was not available for them. And therefore, since one common factor was there was unity among anesthesiologists, and they started thinking what to do to reduce the cost of claims, and then it was taken up by the ASA, and in 1985, the Anesthesia Patient Safety Foundation became a reality. So this was the origin of the starting of Anesthesia Patient Safety Foundation. Now, I will move on to, after this brief history, I will move on to my early years as an anesthetist. My first case, it happened early 1980 after finishing my diploma in anesthesia. I took a decision with confidence to practice freelance in my own town. I bought a free briefcase, small and few endotracheal tubes, red rubber endotracheal tubes, airway gadgets, and waited for my first call. And when it finally arrived, it was an elderly gentleman, Arab gentleman, for an esophagoscopy. OT setup was nothing but a Boyle basic and McGill circuit and section apparatus and all that. No monitors. Finger on the pulse was only monitor and a sphygmomanometer. I was boastful because I was just come out of the university. Induced the patient, intubated, and suddenly the bag broke. So that was my first experience, and the first freelancing experience was a complete flop. And the real trauma was the panic attack it gave me. If it were now, we would call it as a never event. It should never happen now. But then in 80s, it was called as a near miss. My second case was a DNC. The surgeon was a senior gynecologist, retired from medical college. I was only 27 years old. And He laid a law before starting. Before I could start the case, he said, my patient should wake up after I finished. I'll take only 10 minutes. So anesthesia should be short. And the only available anesthetic agent was thiophanone sodium. I gave thiophanone sodium. And to fast forward, the patient did not wake up immediately. So I pinched the nose in between the nostrils. And during that time, the surgeon was standing behind. She became ballistic, furious, and shouted at me. That again, the second call was also a failure. From that day, I have never done this, pinching the nose of a patient to check awareness and to check wakefulness and whether the patient is responding to your pain stimulus. Now there are better methods like tapping the patient, verbal commands, or looking at the vital signs. But that was taught those days, but then after that I haven't done it. And therefore, after the second incident, I bid farewell to freelancing. I didn't want to do that, is not my cup of tea, so I left that. So those days, the only available monitor was finger on the pulse. That is still my top of the line favorite. Least invasive, zero expense, provides real-time feedback even before the pulse oximeter picks. And I insist that all students must keep their finger on the pulse at the time of induction so that you can pick whatever happens to the patient, sudden fall in BP, and also while transporting patients from place to place, whether it's hospitals to another hospital or the same hospital from to one remote area in the same hospital. So keeping a finger on the pulse is extremely important, which is not there now that commonly practiced. What we see now when you step into an operation theater is this. Your finger will be on the mobile. This is a bad thing to do. You must be very mindful and responsible while using mobile phones in the operation room. It should not compromise patient safety. Then Dr. Fani again, in his lecture, again I am referring to Dr. Fanindranath Totta's lecture, he said that use your senses as monitor. And then he said, vision to observe several things. Blood loss, color of the patient, monitor. So use your vision, hearing to auscultate breath sounds and heart sounds, touch to monitor pulse, check expansion of the chest, etc. Smell to guess estimate the inspired concentration of volatiles. And he said, we don't use taste as in monitoring. Instead, we use common sense. And he defined common sense. And he said, my definition of common sense is the willingness and ability to learn and benefit from experience. So this monitoring with the senses is a fundamental of all monitoring. If you do not know fundamental monitoring, then you are not supposed to give anesthesia. All modern monitors are only an extension of these senses. So going next to 1990, I was unhappy with the health service. Then I joined the medical college service. Here I wanted to pursue MD in anesthesia. That is the reason I joined Manipal, KMC Manipal. It was a major culture shock when I came here. Good library, better tools, truly wonderful teachers. And we have two of our teachers, my teachers here, Dr. Ramkumar and Dr. Hanmant Rao. Dr. Anida was my role model. Another senior whom I consider as my role model was Dr. Baliga. He is not here. I don't know where he is. I not met him after that. And now, Dr. Fanindranath Totta was not the head of the department, but he was concentrating on teaching, and therefore I was very fortunate to join at that time. So I will not go into the details of all that now. So 1980 saw rapid growth in medicine and surgery with technological advances in anesthesiology. So there are three stages of technological advances. This can be explained by the tool, the machine, and the automaton. This was done, the classification was done by Rodovan, Richa, and Mazzei Bloomfield. This will help you to understand the evolution of tools in the technological advancement in anesthesiology. The tool gives the human user a mechanical advantage in executing a specific physical task. For example, endotracheal tubes and airway gadgets are tools. The machine, a tool that no longer requires human power but still relies on human control. For example, the infusion pumps we use, the workstations we use, they are all machines. And lastly, automation. Automations are machines that substitutes human control with an automatic algorithm that is often a computer control system. We do not have a total automation in anesthesia, but some of the equipment like machines we use are automated, like the ventilators, it needs minimum inputs. So 1990s, there were refinement of these machines, tools and all that. There were the introduction of LMA and all that, and basic monitoring with pulse oximetry and end-tidal carbon dioxide become essential. Use of computers, processing was there for simulation, for crisis management. As safer and more effective drugs became available, anesthesia tools and machines also became smarter. So 1990, the era of computers and internet was a golden period for anesthesia. And I was very, very lucky to have taken MD during that period, just before that period. Now, the data from the United Nations and WHO shows that globally there are 234 million operations annually. And sadly, up to 3% of these procedures will have a major complication. That is around 7 million. And 1 million people will die during or within the following days after an operation. And most importantly, this data found that nearly half of these complications were preventable. This emphasizes the need for improvement of safety globally. So we are not reached 100% safe. We'll never reach 100% safe, but we have to aim at 100%. So coming to patient safety, the patients we receive in the operation rooms are sick. Most of them are sick. They are in poor health. They are given various drugs. We practice polypharmacy, problems with the drugs, complications of drugs, complications of procedures. Healthcare system itself is complex, complicated. It is more difficult than flying an airplane, though we compare it to the aviation industry. It is multifaceted. So our goal is to keep patients safe and avoid mistakes. But mistakes can happen in spite of having all these equipments. Mistakes can happen. To err is human. We always say that. So to fix these mistakes, errors, we need to do a root cause analysis. We have to find out what is the reason. We have to find methods to prevent such incidences happening. So I'll define some of the terminologies which are in common use with safety. An error occurs when someone is trying to do the right thing, but actually does the wrong thing. A more formal definition of error is the unintentional use of a wrong plan to achieve an aim or failure to carry out a planned action as intended. So for example, I'll give you suppose let me say that I have a habit of giving a sedative like midazolam before I scrub for spinal anesthesia. So I give midazolam just before the patient is positioned, then I go out to scrub. And when I went to scrub, the theater nurse or the anesthesia technician calls me and tells me, doctor, the patient is restless and not doing fine. So I come back to the operation theater, I find my patient restless and immediately understood, instead of giving midazolam, I gave dexamethasone. So this is an error. Your intention is not bad, but what you did is wrong. So this is an error. This happened because I did it myself without any consultation. So coming to the next definition, what is violation? A violation is deliberate. For example, if you are speeding, when the speed limit is 30 and you are speeding at 80, then it is violation. A violation is not necessarily unacceptable. You can do it, but if you deliberately do it, then it can be dangerous. It can be risky sometimes. But appropriate violation is fine. Because suppose, for example, you have a patient who has come for an emergency surgery and the patient is on full stomach, then you take risk. You take precautions so that the patient will not aspirate, and that is appropriate violation. A person committing a violation has no intent to harm, but there is conscious decision to take a risk that is not in the interest of the patient. So why error happen? There are two reasons for error to happen. One is active failure, another is latent failure. Active failure means that something directly injures the patient. So what I told just now, that giving saxamethonium to a patient is an active failure. I did a wrong thing. The mistake is evident there, and you know the mistake, and it is easy to find out. So it is individual dependent. That is active failure. Whereas latent failure is not related to one particular individual. It is related to the system, to the hospital. So several things are involved there. Poor equipment, overactive alarms. There are too many alarms in the intensive care units, and you try to ignore them because there are too many. So that is a latent failure. Poor protocols and procedures and deficiencies in designing the theatre, these are all latent failures. So understanding these failures, both active and latent, is key to improving patient safety. This is an active failure. This person has drove the car into the pond, and that person is responsible for that. It is an example of active failure, but he is a latent failure. This girl is trying to grab something from the shelf, theatre shelf, standing on a stool. It is not the device which has to be used for standing. She may be able to do it 1,000 or 2,000 times, but one day she is going to slip. So this is a latent failure. So there are two types of approach: person approach and system approach. So people make mistakes. That is the reason we all come here to learn, attend workshops, attend CMEs. So lack of training, lack of skills, lack of intelligence. There are people make mistake because of that. And we evaluate and train them. Still they make mistake, and they blame them, they fire them, discipline them, and that is it. That is individual based. So we assume the fault lies within the person. The system approach. In the system approach, it is not the individual that is important, it is the system that is important, more important, to reduce error rate. So it minimizes harm when error happens. So system approach is always appropriate, and that is the way it should be done, and not by the person approach. An example of the system approach is using at least two methods to confirm a patient identity. For example, patient's name, IP number, and date of birth. If you use 3, well and good. So that is one method of system approach. Using standardized pre-op checklist, that is what we all do now. Using WHO checklist before starting your case. Removing lookalike drugs. These are all system-based approach. So coming again to an article, a review article, Obstetric Neuraxial Drug Administration Errors, a quantitative and qualitative analytical review. This came in Anesthesia Analgesia in 2015. The authors identified published cases of neuraxial drug administration errors. They identified and they categorized it into 9 groups, and they gave those 9 groups into experts, and these experts, they created 4 systems to prevent drug errors. And what were those 4 systems? They said, label all syringes. They said, read all labels, double check the label. So these were all the recommendations from the experts. But we have all learned this during the first week of our training. So why should this be told again and again? In spite of telling this, mistakes do happen. And the fourth thing they said was use of non-lower lock connectors. These are connectors which are connected to the IV line so that no syringes, you cannot connect a wrong syringe to a IV line or wrong syringe to a epidural catheter. So this is being used now in US. But again, the first three has to be perfect, then only the fourth will function. If the first three are not good, not functioning, the fourth will not function. Suppose the syringe contains the wrong medicine, the fourth will not function. So this is not perfect. And therefore the Anesthesia Patient Safety Foundation came out with an acronym STPC, which stands standardization, use standardized drug concentration, doses, technology, use technology, barcoding, smart pumps and automated records, and also don't mix drugs in the operation theater, but you get pre-filled, pre-mixed drugs from the pharmacy itself. That will prevent wrong loading of drugs. And lastly, more importantly, culture has to be changed. We need to report errors and learn from those mistakes. Here again another study, catastrophic drug error involving tranexamic acid administered during spinal anesthesia. Tranexamic acid is very dangerous if given into the epidural, into the subarachnoid space. They identified 21 reports of accidental spinal administration of tranexamic acid injected into the subarachnoid space. And what did they? And they looked at the ampules of tranexamic acid and bupivacaine. This is from the journal, both looking similar, and this was a danger. And I looked into my cupboard. What are the ampules like? Then I looked. When I looked, this was the ampule. Again, both looking similar. So there's no, the pharmaceuticals, they don't look at all these. They manufacture like this. So errors can happen to us. So what did happen to the patients? Tranexamic acid has been given. So there is no sensory or motor block, severe pain in the back, buttocks and legs, monoclonus starting in the legs leading to convulsions, ventricular arrhythmias, severe tachycardia, hypotension, and the mortality is 50%. So danger. Tranexamic acid is a dangerous drug. And what precaution do we take now? Did I take now, We have removed all tranexamic acid from the theater and it is given only on request. Coming to another report, drug administration errors among anesthesiologists, the burden in India. This is from an Indian journal, and the conclusion is majority of respondents have experienced drug administration errors at some point in their career. Every anesthesiologist who is practicing anesthesia would have experienced this. An important proportion of these errors have caused morbidity and mortality to patients. The critical incident reporting system should be established for regular audits, an effective root cause analysis of critical events, and to propose measures to prevent the same in future. These are the recommendations from the authors in this journal from India. Now I'll move on to another thing, another important thing that is called as a dangerous intersection phenomenon. In the picture above, you see a junction, an intersection where anything is possible. There is a potential for an accident, but nothing will be done unless an accident takes place. That is called dangerous intersection phenomenon. The lower down, there is another picture. It is a boat catastrophe which happened in Kerala, Kumuli. Many people died in this accident. And when they did an audit on this, what they found out was the boat was very, very old and there were no life jackets in the boat. And then they started, the boat cannot be used, and so they waited for an incident to happen for a correction. This is called dangerous intersection phenomenon. The change in practice before an event happens and not after the event. So it should occur before the event and not after the event. It is very common in our workplace also. The hospital authorities may not buy you an MRI compatible machine because it's very expensive. So until an incident occurs, they buy it. Or you are not able to intubate the patient because there is no video laryngoscope. And we wait for an incident to occur to buy a video laryngoscope. That is a dangerous intersection phenomenon. So coming to closing the loop, how do we close this loop? How do we prevent errors happening? Identifying safety risk is not the problem. We can all identify the safety risk. Recognizing solutions is also not a problem. We can recognize what is the problem, but what the challenge is closing the gap between the identified risk, its solution, and the implementation of practices that will reduce the risk of adverse events. That is the problem. This involves change in behavior and investing in technology to reduce adverse events. This takes place only after the incident has occurred. That is a dangerous intersection phenomenon. I'll give you one more example. This example I've chosen because this happened in our hospital too. A fire incident. If you tell this to a layman, they will be shocked to hear that there can be fire in the operation theater. But in the US, 600 fires happen in 1 year. 600 fires. So because it is very fertile for fire to happen, there is oxygen, oxidizer, there is ignition source, and also there is a fuel alcohol-based solutions. So very fertile and give you what happened in our theater is that the patient was prepped and draped, and the surgeon comes in after that is done. He comes and he take another precaution by pouring some more generous quantity of chlorhexidine on the surgical site, and it happened to be a head and neck surgery under MAC. And then suddenly when he was using a diathermy, fire happened, and nothing happened to the patient though. But this is a dangerous phenomenon, this dangerous thing to do. So what is the problem here? The problem is the Safety Commission, the Safety Foundation has come up with some recommendation that traditional practice of open delivery of 100% oxygen should be discontinued. We should not give 100% oxygen to a patient when it is especially risky to give, when it is head and neck surgery. Use room air when SpO2 is maintained. If the SpO2 is above 94%, why give 100% oxygen? Secure airway, use supplemental oxygen. Suppose you want to give 100% oxygen, then you secure the airway, don't give it via mask. If open delivery of oxygen is necessary, deliver lowest concentration, give only 30% to maintain SpO2 just above 94. Take a timeout before starting surgery. That is a WHO checklist. You see that this is also there in your WHO checklist. Practice change only after the event has occurred. We won't change this practice. So the Safety Foundation, what they did was, they showed this video of fire happening to 10,000 delegates, and they all saw the video. Before seeing the video, the people giving 100% oxygen was 40%. After seeing the video, and they took another survey, and they saw that it is still not 40%, but it's around 20 to 30%. It has not changed. So this change should occur within us. It should be a behavioral change. You can't, it's not easy, but it has to happen. So coming to next one, risk, hope I am on time. Coming to risk analysis, I will just, few more slides only. Risk analysis, there are two models for risk analysis, analyzing risk. Once an error occurs, we should know how it occurred, the root cause analysis, and what can we do to prevent them. There are two models are described. One is called the Swiss cheese model, another is called the bow tie diagram. This is a Swiss cheese model here have depicted an intraoperative hypertension. And these round things are all cheese, layers of cheese, and there are holes in the layers of cheese. If the holes line up, then the barrier is lost. The patient will suffer an accident, maybe an intracerebral bleed or maybe a cardiac arrest. So the incident, these barriers should not align, should not come in one single line, the holes in the barrier. The barriers here are the proper preoperative assessment, BP monitoring, anesthetic management, and team communication. And the layers of cheese represent the healthcare system, and the holes, the potential failures. So this is not perfect. This model is not perfect. It can only identify the barriers. It will not give you any solution to the problem. And therefore, a better tool was devised. This is called as the bow tie diagram. This again is a risk management tool. Here I have shown aspiration of stomach contents. It is called a bow tie because in the shape of a bow tie. In the middle, it is a top event, that is aspiration of stomach contents. On the left side are the causes for the production, for the aspiration to occur, like full stomach, suppressed airway reflexes, incorrect airway management. These are all causes of aspiration to occur. And the barriers are fasting, rapid sequence induction, and placing the patient prop up. The middle is the aspiration of stomach contents, and once the contents has been aspirated, the patient is aspirated, then we should prevent or mitigate the problems that occur after the aspiration. We should prevent the seriousness of the aspiration. What do we do for that? We do proper suctioning, administer antibiotics, and should have close monitoring of the patient. So you prevent or mitigate the consequences by doing before the event and after the event. This would be a better tool to explain the errors that are made. And what are the uses of bow tie diagram? For understanding the risk and how they can be prevented or minimized, preemptive identification of weakness in risk management, investigation of clinical incidents, teaching risk management, and demonstration of risk management strategies to other parties. So this is a good tool for teaching purpose. Now coming to the next thing which I would like to talk to you is about risk-benefit ratio in decision making. In everyday life, we take risk-benefit ratio into consideration. For example, when we are crossing a road, we have decided subconsciously that reaching the other side of the road always is more beneficial than run over by a vehicle. So we have taken that decision subconsciously. It happens in every decision we make. For example, let us talk about fluid administration. We know that prolonged hypovolemia can lead to multi-organ failure. We also know that excessive fluid administration produces edema of the lungs, and hypoxemia, edema in the brain and causing delirium, edema in the heart, producing dysfunction of the heart, edema in the abdominal wall, muscles, subcutaneous tissue. So we know that excessive fluid is dangerous. And the SOAP study has said that excess fluid is an independent indicator of worse outcome in critically ill patients. And therefore, we will have to balance the risk of fluid administration with patient-specific factors. Though this happens everywhere. Whenever we are giving an epidural to a patient, we have already decided this patient will not take whatever the epidural because he is on antiplatelets. We have decided it and we don't do it. So this risk-benefit ratio is very important in decision making. Same with blood transfusion. If you don't give blood, then that will reduce risk, save cost, and improve outcome. This is one of the few areas in medicine where all three can be achieved at the same time. So there are various problems with blood transfusion. can be categorized into 3, and the most common are the TACOD, transfusion associated circulatory overload. That is the most common. Allergic is another one, and RBO immunization is the other one. Those are the 3 commonest ones. The rarest are the hepatitis C, B, HIV, and those are very rare. So before we transfuse blood, we should decide, we should have made the risk benefit analysis and then only given the blood, otherwise you will end up with problems. So coming to the last part of my talk, that is a surgeon anesthesiologist relationship for patients. It's very extremely important to have a good relationship with the surgeon, the patient anesthetist and the surgeon. The surgeon anesthesiology relationship, good relationships involve working well together, respecting each other's opinions, trusting each other's expertise, keeping each other informed on critical decisions. Strong relationships lead to better communication and teamwork. And there could be professional disagreements, but that is okay. But personal conflicts are damaging and can compromise patient care. You cannot be at the head end when you are not talking to the surgeon, when you are not in good terms with the surgeon, and vice versa. How do you communicate with the patient, with the surgeon? It's very, very important to communicate with the patient, the surgeon. So this is one area which has to be taken very critically and very seriously. And when you are practicing in a busy theater, this is very easy to happen, and you must take proper precautions so that doesn't happen. These are some of the stereotypes or negative perceptions of surgeons. They never admit how much blood is lost. The patient, they always underestimate blood loss, and we always overestimate blood loss. They just want to make a lot of money doing more cases. That is what we assume about the surgeon. They don't know anything about medical issues. That is another thing which we always say about them. Always underestimating how long the case will be. When they say 2 hours, we usually multiply it by 4. So this should not be done. This is an irregular thing. You are assuming that is there. So this is dangerous. And vice versa, the surgeon's negative perception of anesthesiologists are, they just want to get home early, don't care about my patient. My patient. They always say my patient. Ready to cancel at the drop of a hat. There is another thing they usually say. They are often distracted, not paying attention. They never tell us about process and which they are using, and also usually turn the monitor away from them. So these are things which we shouldn't be doing in the operation theater. Sometimes can turn out to be a dangerous thing. So improving the surgeon anesthesiology, how do we improve surgeon anesthesiology relationship? Mutual respect, trust, and open communication are the key to a functional relationship. These negative stereotypes are differing values, and differing values can cause tension. Safety is not just about work culture, it is about how people work together, how well they get along, support each other, communicate and collaborate. That is very, very important. Teamwork is crucial for safe, high quality care in surgery. Whatever you have in the theater, very advanced monitors, very highly experienced anesthetists, that is not very, that more than that is the way you communicate in the operation room, the surgeon anesthesiologist diet, that is very, very important. So concluding, safety is doing the right thing because it makes sense. Improved anesthesia patient safety reflects doing a number of little things that in the aggregate make a big difference. Small details in technique make a big difference. So it need not be a big change to make. Two small things. For example, simple example like putting an IV line, placing an IV line, or holding a mask. That again, so simple, but so we did an audit on children below 10 years in the post-operative period about pain. And then when we asked about pain in children, they said they have pain around the mouth and in the hand where the IV line is put. They don't complain of pain in the surgical side because that has already been numbed by us, by caudal or regional blocks. But the pain is there in the limb and around the mouth. The reason is the masks are pressed so tightly that it pains. So that is, even such small things are very, very important in anesthesia. So the closing thoughts, the future of anesthesia safety. As we think about the future, anesthesia safety is always changing and getting better. By using new technology, improving our procedures, and always learning, we can keep giving the best care possible. Let us stay committed to making things safer and making sure every patient has the smoothest, safest experience possible. Thank you.
Thank you, sir, for that extensive oration on patient safety, what we have learned over the past years. I would now like to invite our organizing chairpersons, Dr. Anita Shenoy and Dr. Malvika, and organizing secretary, Dr. Shweta Sinha, and co-organizing secretary, Dr. Suvijit Poddar, onto the dais to felicitate Dr. E.K. Ramdas, sir.
Okay, thank you.
Moving on to our next session, I invite Dr. C.L. GURUDATT onto the stage. Dr. GURUDATT is a former HOD of Department of Anaesthesia, Mysore Medical College and Research Institute, and JSS Medical College, Mysore. He has over 40 national and international publications. Today he will be giving us a lecture on the physics of vaporizers. Over to you, sir.
Good afternoon, everybody. First of all, I would like to thank the Department of Anaesthesia, Kasturba Medical College, Manipal, for this opportunity. You know, when anesthesia was born on 16th October 1846, W.T.G. Martin, so used a very simple, the vaporizer, you can call it, which was really ingenious. But the main problem with that vaporizer was there was no means of regulating output concentration or compensating for temperature changes. Now what we have highly sophisticated vaporizers, ultra modern vaporizers. They are electrically heated, electronically controlled, and most of these vaporizers, they meet the characteristics of ideal vaporizers, like they deliver a fixed desired concentration, they are agent specific, absolutely no effect on back pressure, easy to maintain and clean. And we all know that almost nearly 95% of the cases every day we do under general anesthesia will be using the inhalation anesthetic agents, and for delivering these inhalation anesthetic agents, you do require these vaporizers. And maybe another 5% of cases we'll be doing under total intravenous anesthesia. Since we are using these so many, for so many patients, we keep using these vaporizers, it is very important to understand what is the physical principles by which these vaporizers function and what is the physics behind these physical principles. So let us know about these physics and the physical principles behind these vaporizers. We all know that the matter exists in three states: solid, liquid, and gas. So definitely, the solid is a rigid thing, and the molecules are so tightly packed, they don't move at all. Whereas with the liquids and gases, the molecules are not so tightly packed, they keep moving and they flow, and hence these liquids and gases are called as fluids also. And this, whatever the state of the matter, is not a constant one. Based on the temperature and pressure, it can keep changing. You can see here, so the solids can change over to liquid based on the pressure and temperature, and also they can change to vapor also. But once they reach a particular temperature, the solids, liquids and vapors cannot stay in that state. They get all converted to gas, and this temperature is called as a critical temperature. And what is the critical temperature? It is the temperature above which a gas or any fluid cannot be compressed into its liquid state with whatever the pressure you apply. So that means, above the critical temperature, it is always the gas, and below the critical temperature, we call it as a vapor, though it's in the gaseous form. And this vapor can also be compressed into its liquid state. Example for this critical temperature, invariably you will be asked in the exams. So critical temperature of the nitrous oxide is 36.5, and the critical temperature of oxygen is minus 118 degrees centigrade. So that is the reason, because the critical temperature of nitrous oxide is much higher than the room temperature. It always remains as a liquid in the OT at room temperature, whereas oxygen always will remain as a gas at room temperature. So most of our inhalation anesthetic agents, what we use, they have a very high critical temperature. Hence, they always will be in the liquid at room temperature. But when these inhalation anesthetic agents are kept in an open container, they start vaporizing, the molecules will gain a lot of kinetic energy, and they come to the surface, and from the surface they enter into the vapor phase, and after some time you may not find any liquid in the container. But if the same liquid is kept in a closed container, what will happen is the molecules which gain the kinetic energy come to the surface and then enter as the vapor phase, and these molecules will start bombarding against the wall of the container, and also they start bombarding against each other. They produce a pressure, and this pressure is called as the vapor pressure. And also what is going to happen is, some of the molecules which enter into the vapor phase also will get condensed to the liquid phase again. And at a particular temperature, the number of molecules entering into the vapor phase and the number of molecules entering back into the liquid phase becomes constant, and then you say that the vapor has been saturated or an equilibrium state has achieved at that particular temperature, and the vapor pressure at that particular temperature and equilibrium state is called as the saturated vapor pressure. And the saturated vapor pressure entirely depends on the temperature, and it does not depend on the ambient pressure. This is another very important aspect we should always know. Here you can see at 20 degrees the number of particles which are entering into the vapor phase are very minimal. At 37 degrees when it is heated up, the number of particles entering into the vapor phase are many. That means the saturated vapor pressure will increase with increasing in temperature. That another important thing here is the pressure depends on the number of molecules in the vapor phase. So this is basically based on the universal gas law, where it's a universal gas law is a combination of Boyle's law, Charles' law, Gay-Lussac's law, and Avogadro's hypothesis. By combining all these, we get this, the equation PV is equal to nRT, where the pressure is directly proportional to the number of molecules and inversely proportional to the volume, provided you have temperature kept constant. That means the number of molecules will decide the pressure, and the number of molecules is decided by the temperature. So very important that this saturated vapor pressure is agent specific, temperature dependent, and totally independent of barometric pressure. And some of the saturated vapor pressures of different inhalation anesthetic agents we routinely use is this, and many of these inhalation anesthetic agents have very high saturated vapor pressure. And one more thing is the saturated vapor pressure and volatility are directly related to each other. Higher the saturated pressure, more will be the volatile the liquid is. And majority of our inhalation anesthetic agents have got very high saturated vapor pressure, especially the desflurane. So that's why all these are called also as volatile anesthetic agents. Coming to one more important thing is the boiling point. So the boiling point is defined as that saturated vapor pressure when it equalizes with the atmospheric pressure. That is the temperature at which saturated vapor pressure will become equal to the atmospheric pressure. Normally also when you keep a liquid in a container, so the liquid, whatever the particles, they try to form bubbles within the liquid. But these bubbles are crushed by the increased amount of atmospheric pressure that is always there above it. So, but the boiling occurs only when the atmospheric pressure and the saturated pressure becomes equal. So then there is no excess atmospheric pressure to crush these bubbles. And one more thing is the vaporization is a surface phenomenon, whereas the boiling is a bulk phenomenon because the bubbles occur inside the liquid itself. And it is very important for us to know but this particular thing about the boiling also, because the boiling entirely depends also on the temperature again. Because if you start increasing the temperature, so the vapor pressure, saturated vapor pressure may become equal to the atmospheric pressure and boiling will occur, and it is agent specific. And more important thing is that it depends on the atmospheric pressure, because once the atmospheric pressure is lower, for example, if I take a liquid to a high altitude area where the atmospheric pressure is lower, at that particular atmospheric pressure, the liquid will start boiling at a lower temperature itself. You can see water boiling at 100 degrees centigrade, and as the altitude increases, now the altitude is increasing, the atmospheric pressure is decreasing, so also the boiling point also will decrease. Like for example now, as I told you that water boils at 100 degrees at sea level, whereas it boils at just 90 degrees at 10,000 feet. The same thing is very important for the inhalation volatile anesthetic agents as well, because now all these vaporizers are calibrated at 1 atmospheric pressure. Suppose if I take this vaporizer to a high altitude area, and where the inside the saturated vapor pressure has become equal to the atmospheric pressure and the liquid starts boiling, then you just cannot have any control over the output concentration. You cannot have or use that vaporizer at that very high altitude area. So you have to really calibrate, or you have to go for a different kind of vaporizer. So that is very true with the desflurane normally. So desflurane has got a very low boiling point, just about 22.8, and many times it can even boil at just above the room temperature, suppose the body temperature increases. So you cannot use desflurane in an ordinary regular variable bypass vaporizers like we are using the other one. It requires a specialized vaporizer for that. So that is the importance of knowing about the boiling point. The next thing is the latent heat of vaporization. So you see, when I was telling you, when you keep liquid in a container, so these molecules will gain the kinetic energy. They start entering the surface and they start vaporizing. And where do they get energy to come to the surface and to become vapor. It is hidden, that heat energy that is hidden inside the liquid is the one which is used up by this liquid. Because it is hidden, that energy, that heat energy, we call it as the latent heat of vaporization. And that is defined as the heat energy required to convert 1 ml of a liquid into vapor. So what happens when this heat energy is taken away by these molecules? The liquid cools. Once the liquid cools, there is not much of a heat available for the particles to enter into the vapor phase. So because the number of particles is directly proportional to the vapor pressure will fall. The output concentration in a vaporizer will also come down. This same thing gets exaggerated when the gases are passed over the liquid surface, because they take away more amount of heat, and once more heat is taken, again the liquid further cools and the output concentration suffers. So the liquid requires heat energy to maintain a constant temperature, and many times this heat energy it can take from the material, the wall of the material that is used for the manufacture or of these vaporizers. And this heat energy that is present within the wall of the container in the metal is called as the specific heat. It is described as or defined as the amount of heat required to change the temperature of a unit mass of a substance by 1 degree Celsius. And this is very important as far as the construction of a vaporizer is concerned. If the specific heat is of the material is very high, that means it will not get cooled immediately. It can keep on providing sufficient amount of heat energy to the liquid so that the liquid continuously evaporates. So that is the importance about the specific heat. And one more thing is about the thermal capacity. So the thermal capacity is defined as that the specific heat multiplied by the mass of the metal. So if this thermal capacity is high, so then the liquid can get enough of heat energy from this material itself. You must have seen that majority of our vaporizers are very heavy. So why they are made heavy is mainly to increase the thermal capacity. Their walls have been made very thick, so that is the reason they are very heavy. But after some time, what will happen is it cannot keep on giving the heat energy. It also cools, but then the liquid cools. But if the outside temperature can be transmitted to the liquids, so then there won't be much problem as far as the vaporization is concerned. And the rate of transfer of the outside temperature is called as thermal conductivity. And it is also very important as far as the metal what we use for manufacturing these vaporizers or construction of these vaporizers. So the majority of the times what we have nowadays, we have copper, bronze or stainless steel for manufacturing these vaporizers, because they have high specific heat and high thermal capacity based on the mass and high thermal conductivity. One more concept you should always understand is the MAC and MAP. MAC, you all know that it is defined as that minimal alveolar concentration which can prevent skeletal muscle movement in response to a noxious stimulus in 50% of the individuals at 1 atmosphere. So this is what always you have to talk about, because whatever the inhalation anesthetic agents we use, they act by formation of the vapor, and vapor acts like a gas, and gases will move from one area to the other area, or one surface to the other surface by partial pressure gradient, and also they act by their partial pressure gradient and not by volume concentration. That is why now the new concept of MAC is the MAP, that is minimal alveolar partial pressure. So you should always understand it is the partial pressure of the gas which acts on the brain to produce an anesthetic effect. So that's how, if you just convert the halothane or all these MAC value to the MAP value, you get these millimeters of mercury. So why we should know about this? So suppose I take this vaporizer to a other higher altitude area where the altitude, the atmospheric pressure comes down, then when I multiply this Mach with this atmospheric pressure, the MAP value will come down. But because it is a MAP which is more important than the Mach value, so then unless the concentration is increased or this MAP is maintained, this partial pressure in the brain is maintained, so the patient will not have the same effect as the Mach value of 0.7 at 760 millimeters of mercury. So very important is to understand or convert this Mach into the partial pressure. So whenever we talk about the partial pressures, we always talk about the Dalton's law of partial pressure. So it says that in a mixture of gases, the total pressure is equal to the sum of the individual partial pressures. Like here, we have the total pressure, we have gas A, B, C, and D. So the total pressure is when you combine the partial pressure of these individual gases. So another important thing, that in order to calculate or to know what is the partial pressure, you just have to know what is the fractional concentration of that particular gas in a mixture. If you multiply the fractional concentration with the total pressure, you get the partial pressure of that, the particular gas in that mixture. That's how, for example, in air we have oxygen, which is 0.21%. So 0.21 multiplied by 760, you get 158 millimeters of mercury. So the partial pressure of our inspired oxygen, PiO2, is 158 millimeters of mercury. But the thing is, when we have the vaporizer, we don't mention with the partial pressure. We always mention with the volume percentage, volume by volume percentage. So you'll have to convert this partial pressure in order to know what is the volume percent. So then you have to use this equation is once you know the partial pressure, you divide it by ambient pressure multiplied by 100, you get the volume percent. So why this volume percent is important? The partial pressure, saturated vapor pressures of these inhalation anesthetic agents are these. When we convert that into volume percent, we get these volumes, that is at 760 millimeters of mercury. So this is because 243 divided by 760, you get 32, and like that. So why it's again important is if I give this 32% of halothane, where its actually concentration is just 0.7, it will be too much for the patient. Actually, he may even die. So these, high volume percent has to be reduced to therapeutic concentration, and that's how you require the vaporizers. And that's how the vaporizers will convert this high concentration of these vapor that is generated within the vaporizing chamber to the therapeutic concentration or whatever you set. So how they convert is how we classify these vaporizers. That is another very common question that will be asked for you in the exam. So there are various methods by which we classify this, and originally it was classified by Dodge and Dodge in 1979 to like the regulating output concentration, method of vaporization, agent specificity, location in the circuit, temperature compensation, and resistance. So each one of these things was taken into consideration while classifying a particular vaporizer. But the newer classification is what we have is based on the method of regulation of output concentration. That is, we have a variable bypass vaporizers and measured flow vaporizers. So variable bypass vaporizers, we have Tech series, we have Aladdin cassette vaporizer, of course. The Aladdin cassette vaporizer also sometimes can also act like measured flow vaporizer. And in measured flow vaporizers, we have Desflurane vaporizers, we have Draeger Diva, the Market 950 series of vaporizers. So the other classification I was telling you about, the method of vaporization. So majority of our modern vaporizers, they are flow over vaporizers. So these are the flow over vaporizer. They just, the gases will flow over and pick up the vaporizer, vapor, and then go to the outlet. Whereas the older vaporizer, one of the older vaporizer, which was, the copper kettle vaporizer, so that had a bubble through type of method of vaporization. Of course, our Boyle's bottles also could be converted into bubble through. The third type of vaporization is, the injector type of vaporization that we have in most modern vaporizers like Diva, and also in case of market 950 series, we have this injection type of vaporization. Agent specificity, all our modern vaporizers are agent specific. And this is actually done by various methods, so that wrong agent is not filled in a particular vaporizer, is by color coding, the agent specific filling system, and agent gas monitors also will prevent wrong agent filling in the vaporizers. So resistance, as far as resistance, we classify them into plenum vaporizer and the draw-over vaporizer. The plenum means, under pressure, the gases enter into the vaporizing chamber, pick up the vapor. Whereas draw-over is the patient creates a negative pressure. Under negative pressure, the gases will flow over the liquid vapor. So all our modern vaporizers are plenum vaporizers. And another important thing, you will be asked about the location of the vaporizer in the circuit, whether it is within the circuit or outside the circuit. All our vaporizers, because they are high resistance vaporizers, they are all kept outside the circuit. We don't have vaporizer within the circuit. Then coming to the temperature compensation, we have various methods of temperature compensation. We have supplied heat, we have alteration of the flows, which is done by the bimetallic strips in majority of our routine variable bypass vaporizers. We have electrically heated desflurane vaporizers, electronically monitored Aladdin cassette, Draeger, Market vaporizers. So how this alteration of flows of is done by the bimetallic strip. So these bimetallic strips are actually, they have two metals joined together, and each metal has got a different coefficient of expansion. Because it has got a different coefficient of expansion, what will happen is, so at a particular temperature, when it is increased, one metal may expand more, the other metal may not expand that much. The opposite occurs when the temperature falls, one metal contracts more, the other metal may not contract much. So what happens is, the strip will bend. So because of the bending of the strips, so what will happen is, you can see bending of the strip will alter the amount of flows going through the bypass chamber and the amount of flow entering into the vaporizing chamber. Coming to the variable bypass vaporizers, so how do they function? Normally when the fresh gas flows into the vaporizer, so it is two portions. One is the bypass flow and another is the flow, a small flow that goes into the vaporizing chamber, and this is going to pick up the vapor, comes back at the outlet, again the bypass flow and the flow entering into the vaporizing chamber will mix, and finally because it gets diluted by the bypass flow, whatever the concentration you have dialed, you will be getting it. And the other important thing for you for the exam is again splitting ratio. Invariably you will be asked what is the splitting ratio. It is the amount flow entering in the bypass chamber divided by the flow entering the vaporizing chamber. So why should we know about this splitting ratio? Because this splitting ratio is, it is depends on the anesthetic agent, it depends on the temperature that is there inside the vaporizing chamber, and also it also depends on whatever you choose the concentration of the vapor for the patient. So for example here, you see if 3069 ml of the fresh gas enters the vaporizer, and so 3000 ml for example now it goes through the bypass chamber, 69 ml enters into the vaporizing chamber. Now this is isoflurane vaporizer, and it can pick up about 31%. Already we have calculated 240 is the saturated vapor pressure divided by 760, you get 31%. So in order to get 31%, now it will be picking up 50 ml of the vapor. That is because, if the 69 ml is the 69%, and sorry, it will pick up 31 ml because 31% is 31 ml. So how much it will come out? It will come out as 100 ml. So once the 100 ml comes out, so 100 ml will combine with 3000 ml. So total it will be 3100 ml and out of 3100 ml, you have 100 ml as the, total it comes out, 3100 ml, and it is, 100 ml is, 31 ml is the vapor, so it will be 1%. That is what it is there here. So what is the splitting ratio? Splitting ratio will be 3000 divided by 69. It is 44:1. And many of these individual anesthetics will have a different, I told you that it is agent specific, depends on their vapor pressure. So that's how you cannot use a wrong agent in a particular vaporizer. So that is very, very important because the splitting ratios are different. And second thing is the splitting ratio keeps on decreasing as you want increased amount of the vapor output concentration, because you want more gases to enter into the vaporizing chamber and pick up the vapor. Coming to some more advanced vaporizers. So one of them is Aladdin cassette vaporizer. Again, it's a, I told you it's a, majority of the times it works as a variable bypass vaporizer, and also it can work as measured flow vaporizer as well. So it is electronically controlled vaporizer, and it can be used for many of the agents, but individual agents is for represent a particular cassette. The cassettes are color coded, and very important to know that this whatever the cassette where we fill the liquid anesthetic is actually the vaporizing chamber, and the control unit is present inside the anesthesia workstation. That is why you cannot use these kind of cassette vaporizers in any other workstations. They have to be used only either in the ADU, S4 ADUs, or nowadays it's more commonly used in ISIS CS² vaporizer, anesthesia workstations. So here, the CPU will be there, and CPU will control everything, including it will be getting information from whatever we set, and also it will be getting information from the vaporizer, the pressure, the temperature, and everything is controlled by the the CPU. It also will be getting information from the gas flows also. So finally, it will decide how much of the output concentration. So it's totally electronically controlled vaporizer. Coming to the measured flow vaporizer, I will not go into details about this particular measured flow vaporizer. This is a copper kettle which hardly we will be using. So the other important measured flow vaporizer, what we use is Detex Umada Tech 6 vaporizer. You all know Tech 6 vaporizer, it's mainly used for desflurane, because desflurane, its boiling point is very close to the room temperature, 22.6. So at just above the room temperature, it may start boiling. The other most important thing is, because it is so highly volatile, its saturated vapor pressure is very high. It is 669 millimeters of mercury. So suppose if I want to use the desflurane in a variable bypass vaporizer, suppose if I pass 100 ml of the gas through the vaporizing chamber, it will pick up nearly 780 ml of vapor because of high saturated vapor pressure. And in order to get 1% of the desflurane vaporizer, I have to use the total fresh gas flow as 78 liters, which may not be possible at all. That is the reason you cannot use desflurane in a regular, ordinary variable bypass vaporizer. You require a specialized vaporizer, that is a Tech 6. So another important thing is here the liquid desflurane is heated but to 39 degrees, and the pressure what we get is almost about 1500 millimeters of mercury. Why it is again to be heated? This is again another common question you will be asked in the exam. Because desflurane, the vapor pressure is so high, and also it is boiling point is so low, it may start boiling. Once it starts boiling, it loses a lot of its temperature. Afterwards, what happens is the output pressure will be very less because the vaporization will come down. So you cannot maintain a constant output concentration. That is why if we keep a constant pressure of desflurane, so that, and also it has got two circuits, one circuit separately for the fresh gas flow and another circuit is for the desflurane. So we do have a differential pressure transducers, we have control electronics, and all these, what they will do is, they bring the working pressure of the desflurane circuit and the fresh gas flow circuit, so that the output concentration will always remain whatever we have set. That is, you can always set it by, this is the concentration control valve. So the feedback will be from the control electronics and the differential transducer. So the working pressure will be maintained, and because of that, a constant outlet pressure will be there, outlet concentration will be there. Similarly, we have the DIVA, it's a direct injector of volatile anesthetic vaporizer, which is specially there in Zeus anesthesia or Draeger workstation. So here again, we have a liquid agent, and by gravity it comes into the pressurized tank, and from the pressurized tank it is now controlled by the central processing unit, and how much of the vapor has to enter into the, or how much liquid has to enter into the vaporizing chamber will be decided by the CPU, and whatever you set will be, it will be giving. The same with market injector vaporizer. Similarly, it's an injector type of vaporizer. Lastly, the factors affecting the vaporizer output. So we have various factors: the gas flow rate, the temperature, the carrier gas composition, and the altitude. In that, anyway, because we know that the temperature, majority of our vaporizers are temperature compensated, carrier gas will not produce much significant change in the output concentration. It is more important is the fresh gas flow. Suppose if the fresh gas flow enters the vaporizing chamber very rapidly, it will not be able to pick up the vapor much because it will not have time. It is coming out very slowly also, it will not pick up any amount of vapor. So in order to prevent that, we have the wicks and then the baffles. So the wicks will increase the surface area, the baffles will produce some amount of resistance, so that the enough time will be there for picking up of the vapor. The last thing is about the altitude. So this is again very important for your examination purpose, because volume percent, I was telling you always, will be calculating based on the partial pressure divided by the ambient pressure. So the volume percent definitely will increase if the ambient pressure starts coming down, because it is a partial pressure divided by ambient pressure. So if I take this vaporizer to a high altitude area, so what I have to do? How do I know what is the amount of output concentration that is coming out of the vaporizer? So that I can calculate by this equation. You should always know about this equation. So percentage of agent delivery at high altitude is percentage of agent calibrated at 1 atmosphere multiplied by the atmospheric pressure divided by the pressure at that particular given altitude. I'll just give you an example. If I am having 2%, and another very important thing I want to tell you is about the MAP, minimal or partial pressure. I'll just tell you how it will be when I take the vaporizer to a high altitude area. So if I have a vaporizer at 760 millimeters of mercury and output concentration I am keeping it 2%, what is the output partial pressure I will be getting is 15.2 millimeters of mercury. The same vaporizer, I take it to an altitude of 380 millimeters of mercury of atmospheric pressure, then actually output concentration, though I am keeping it as 2%, I will be getting it as 4%. But what is this partial pressure of this particular 4% is only agent partial pressure is again 15.2. So the partial output of partial pressure of the agent will not change, and it is a partial pressure which will be effective on the brain, and hence the effect on the brain does not change. But this is not with the desflurane, because desflurane is, the output concentration is always whatever may be the ambient pressure, the output concentration, whatever you have fixed will not change. It is same with DIVA and also with market vaporizers. So the back pressure effects, now hardly there is any back pressure effect. It has been looked after by various measures like non-return valve and longer inlet to the vaporizing chamber. So just to conclude, so below the critical temperature, the liquid anesthetic exists as vapor, and when saturated vapor pressure equals the atmospheric pressure, the liquid begins to boil. Saturated vapor pressure depends on the temperature and not on the ambient pressure. And materials with high thermal conductivity in specific heat are preferred for vaporizer construction. And we have two types of mainly the vaporizers, variable bypass and measured flow, and desflurane requires a specialized vaporizer. Thank you. Thanks for extra time that has been given to me.
Thank you, sir, for illuminating us with the intricacies of physics of vaporizers. The floor is open for queries from the audience.
Because vaporizers are a very important topic for exam purpose. Theory questions also will be asked, and lot of questions will be asked in the practicals.
Next, we have a pro-con session. I would like to invite on stage our moderators for the session, Dr. Sumesh T. and Dr. Lakshmi Shenoy. Dr. Sumesh T. is a professor and head of the Department of Kasturba Medical College, Mangalore. And Dr. Lakshmi Shenoy is Associate Professor at Kasturba Medical College, Manipal. Dr. Akshay Kamath, Junior Resident, KMC, Mangalore, and Dr. Soifa Sharif, Junior Resident, KMC, Manipal. We welcome the speakers.
Good afternoon, everyone. We are a group of young people that are, we are standing in between your culinary feast. But then we thought we might introduce some education and entertainment on the topic of airway management for short procedures under general anesthesia involving laparoscopy. So we thank the chairpersons for the kind opportunity, and we've got two young people here. There is Dr. Akshay Kamath from KMC Mangalore. He's also an MBBS gold medalist, and we have Dr. Sophia from KMC Manipal. So rather than look at this as a pro-con session, let's look at it as two ways of, looking at something, in this case, airway management.
So you're all very familiar with laparoscopic surgeries, which is frequently where pneumoperitoneum is present. So during these surgeries, it is very standard to use endotracheal tube to intubate the patient. But recently, with the supraglottic airway devices, second generation and especially third generation coming up, a lot of anesthetists are considering if there is any benefit in using those. I would start my presentation by thanking my opponent for agreeing to take the weakest position in the pro-con debate. Now we'll start with the pros of an endotracheal tube. It's very evident that it protects absolutely against gastric aspiration, hence it's the gold standard. It allows for optimal control of CO2. It's easier to manage with higher airway pressures as frequently encountered during pneumoperitoneum and the various exotic positions the surgeon requires. Everyone is familiar with its use, and its availability in all settings is present. Coming on to the cons of a supraglottic airway device, here a second generation supraglottic airway device is a must for a laparoscopic procedure. The proper use is required for good airway protection, the proper seal. We may need multiple maneuvers to properly place it, like the Chandy maneuver. And if a surgeon requires a certain position, it may not be the ideal device. Ever heard of an LMA protector? It's considered as the standard to be used during laparoscopic procedures. It's the ideal LMA with a higher sealing pressure to prevent aspiration and to prevent leak. I'll come more to it later. One more thing about supraglottic airway devices, even though it is soft, the airway is softer. So here it can still cause more trauma. There is higher incidence of laryngospasm, and the incidence of nausea vomiting is not low. Intraoperatively, it may be displaced and may further require intubation itself, where you will have to further intubate in the abnormal position, which may extend the duration of surgery, which may worsen the recovery, and we may require post-op ventilation as well. Now continuing into the cons of second generation supraglottic airway device, it has a very low threshold for leak pressure. It's just 25 centimeter of water, which requires the use of pressure control ventilation to reduce, to keep a lower pressures as needed. For example, IGEL and LMA Supreme have only 20 to 25 centimeter of water as their seal pressure, beyond which the seal is reduced and there's a leak. LMA Pro Seal is slightly better, having 25 to 30 centimeter of water, and LMA Protector is again at that range itself, around 25 to 30 centimeter of water. You can't perform lung recruitment maneuvers with a supraglottic airway device. The outcome is worse, and it can further worsen the risk of gastric aspiration as well. To maintain a baseline PEEP, it has been found that the incidence of displacement of the supraglottic airway device is high. So here, it may require further repositioning of the supraglottic airway device in the middle of the procedure multiple times to get an effective seal. Then further, multiple studies show that there is a high chance of poor ventilation, that is suboptimal ventilation, especially due to the necessitation of pressure control ventilations, which can lead to hypoxia. Then for obese patients, it is not the method of choice, especially in the BMI of greater than 30 kg per meter square. All the studies done consider that itself as an exclusion criteria. So the use of a second generation supraglottic airway device is tenuous at best. Then for longer procedures also, it's not ideal. We can have failure of ventilation, the higher pressures can dislodge, then there will be air leak. Then coming on to aspiration, the risk of aspiration is very high. One of the reason is because an LMA will produce gastric insufflation, and it has been found that just at the pressure of 20 centimeter of water, there can be gastric insufflation. It's very simple to note, to find out how this happens. That is, just place an ultrasound probe on the lower gastroesophageal sphincter, and a comet tail artifact will be produced every time there is a the air enters into the stomach. So we regularly encounter pressures of 20 centimeter of water. So that is one significant issue. Then putting an LMA itself increases the airway resistance, increasing the peak pressures. That itself worsens the status. That is a great disadvantage. Then coming to the ideal LMA, here an LMA protector, this is a diagram of the same. It is considered as the best LMA for laparoscopic procedures, mainly because in the cuff there is a high seal pressure. That is what they claim. But the thing is, it produces no significant difference in pressures from ET tube, for example. So it is costly and it doesn't produce effective ventilation in certain cases. Now, there is no significant evidence telling that it is beneficial. Even though people are using it significantly, there is a deficiency in the literature where LMA protector is considered as the ideal choice. Then coming on to aspiration, which is our main concern, ASA has published closed claim cases where these are the cases which have gone to court and been settled. Here, 5% of the cases from 2000 to 2014 were pure aspiration cases, which are considered mainly the anesthetist's responsibility. Here, 57% of those cases which were aspiration claims, 66 were such that patient deaths had occurred. So we should never underestimate aspiration. The shocking fact is that 63 out of those cases were occurring during elective surgery where the claim was made that NPO was adequate. There is an incidence right now of 1 in 1,000 patients who aspirate even with adequate NPO, half of which end up fatally. See, in multiple ultrasound findings are there where 7 to 15% of patients we can find either solids or greater than 1.5 ml per kg of gastric fluids. That is considered a full stomach, despite adequate NPO. So even if NPO is there, you cannot be assured that the stomach will be completely empty. The risk of aspiration is still present. Multiple studies are there to equate to the same. Preoperative assessment of gastric contents and volume using a bedside ultrasound in adult patients shows that 85% of patients had clear liquids and 6% of patients had solid content. Ultrasound assessment of gastric contents in patients undergoing lap cholecystectomy, it was found that such patients who were given preoperative carbohydrates were found that there's a 2-hour delay in gastric emptying as well. So out here it is better to be safer than sorry, because generally speaking, if you're sorry many of the times, the patient will be. So it's clearly that an ET tube is a safer choice than an LMA for laparoscopic cholecystectomy. Thank you.
Thank you, Dr. Akshay. For a very long time, all of us have been using endotracheal tubes. You know, it has been the gold standard for laparoscopic surgeries. But with the introduction of second generation supraglottic airway devices, which are known to have much better properties when compared to the first generation, they are known to have better gastric seal, they are higher oropharyngeal leak pressures, and rest of it, Soifa will actually convey through her talk. So we will not give up on supraglottic airway devices as well. So Soifa, please continue.
Very good afternoon to everyone present. I am Dr. Soifa from KMC Manipal, and I will be putting across my position in this session, which is in favor of using second generation supraglottic airway device in laparoscopic surgeries, which is considered unconventional and controversial till now. But by the end of this session, let's see if we can see a new perspective. I'd like to start with a gentle reminder that we are all fond of SADs, and it has been hailed as one of the greatest inventions in anesthesia in the recent decades. And like any significant invention, initially it underwent a lot of scrutiny and rejection until Dr. Archie Brain received his well-deserved recognition for it. And yes, it has its limitations, some of it which we can't help, such as a reduced mouth opening or an injured airway. But some other factors such as positioning of the patient, aspiration risk, anticipated high inspiratory pressures during ventilation, all of this which are seen in laparoscopy, which is our topic today, does it still hold true when it comes to a second generation LMA? Because the second generation LMA was formed to counter these. So is there enough evidence to counter this and say otherwise? And can we reconsider our airway choice during a laparoscopic surgery? So when we speak about this, let's dive right into the most dreaded complication, which is aspiration, regurgitation, and gastric insufflation. When we talk about this, it's important to consider the NAP4 findings on major airway complications, which identified aspiration as the leading cause of mortality with an impact of 50%. In the cases that had aspiration, 13 had classic LMAs, 1 was iGel, and 8 were ET tubes. So the debate that was sparked was whether SAD is better than classic LMA, and the recommendation ultimately was, when tracheal tube is not indicated, use a second generation instead of a classic LMA. So coming more specifically to laparoscopic surgeries, here you see two studies done with ProSeal LMAs, endotracheal tube versus ProSeal in laparoscopic surgeries. In none of the patients was there aspiration, regurgitation, or associated gastric insufflation despite high pressures. This is a different second generation airway, LMA protector. The LMA protector has an esophageal seal. It isolates your respiratory tract and your digestive tract from each other. So at the end of both the studies, they did not find any significant aspiration in either of the groups. One more study where they did endoscopic check of aspiration, they did not find any, and another one where they concluded that there was absence of any clinically significant microaspiration with ProSeal LMA. One study where they compared the gastric insufflation using USG. The antral cross-section was checked using ultrasound for ET tube and LMA iGel patients. Both groups, all three groups, had same amount of insufflation, and none of the patients had significant aspiration. These two are also very striking studies because one was done laparoscopic living liver donor hepatectomy. It's a lengthy laparoscopic procedure done under LMA, and it showed no sign of aspiration in 45 cases. And the second one is a lap donor nephrectomy done in lateral position. Again, lengthy procedure with no signs of aspiration at the end of the procedure in 152 cases. One last study in this category is the BASCA mask was compared with the endotracheal tube in laparoscopic surgeries. In both groups, they inserted Ryle's tube, and in the Ryle's tube, they inserted methylene blue. At the end of the procedures, none of the patients had tracheal or oropharyngeal blue staining, indicating that the stomach contents were not regurgitated. Okay. till here we saw a lot of evidence suggesting that aspiration is possibly not a problem. So is ventilation and oropharyngeal leak really a problem? Let's see. This is a study on prolonged abdominal lap surgeries in which they did not find any statistically significant difference in ETCO2, respiratory rate or peak inspiratory pressures. At the end of the surgery and in between surgery, they did ABGs to see the PaCO2, PO2 levels, again showing no significant difference, ensuring effective ventilation. Most studies showing guaranteed effective ventilation, no significant difference in SpO2 or ATCO2, and no clinically audible leak throughout the laparoscopic surgeries. This again is one novel study because this is one study they have done on morbidly obese patients undergoing gastric banding laparoscopically. Here also they used PLMA and they did not find any patient to have aspirated the contents, and it was done on more than 100 patients. Again, the same nephrectomy. In that study also, they evaluated the ventilation parameters, which showed no cases of intra-op desaturation or even hypercapnia. And lastly, one study involving the IGEL in pediatric patients yielded the same positive findings. Okay, suppose now we satisfied with ventilation and aspiration risk. Now there are even more pros for LMAs. Yes. We can say that it reduces the hemodynamic and hormonal stress response and decreases catecholamine release with reduction in use of anesthetic and analgesics. It leads to a significantly lower heart rate and blood pressure, providing cardio and cerebroprotective benefits for at-risk patients who cannot tolerate high oxygen demands and fluctuating vitals. These benefits are supported by numerous studies, and we have seen it by ourselves in our operating rooms as well. Moving on to laryngopharyngeal morbidity, these can be from minor complications like a sore throat to major complications like stridor causing airway obstruction. Sore throat, although seemingly a minor complication, can be very distressing for the patient, has been shown in multiple studies to be as much as 44% reduction compared to the endotracheal tube. Other key findings included less irritating on the laryngeal mucosa, less damage to the pharynx, and lower frequencies of desaturation and laryngospasm and coughing. This is particularly important when we do cases with pediatric patients with uncomplicated URTIs because they have a greater propensity to suffer from spasm and coughing and desaturation in this population. We all know that a decreased airway manipulation with an easy first attempt success, which is higher in LMA, decreases respiratory complications. Another seemingly minor but upsetting for the patient is PONV. Numerous studies have showed that when you use an LMA compared to ET tube, the PONV is significantly lower. And at emergence and extubation, it is smoother, easier to extubate. And ultimately, it all leads to a quicker discharge. One study showed that when you use an SAD during the anesthetic for a laparoscopic gastric banding, the patients met the discharge criteria 17 minutes earlier. So we can see now that the second generation SADs are safe and effective for lap surgeries, and the patient inclusion criteria for SADs use are expanding as we uncover their definitive advantages over endotracheal tube, which are hard to deny after we see all this evidence.
Right. So we've had two viewpoints here, and both presented a lot of good sides for the equipment that they represented. So if we look at today's keynote address, it was all about safety in anesthesia. So at the end of the day, that's what we are looking at. We and our patients have to go home safe. So for short laparoscopic surgeries under general anesthesia, which may or may not involve the use of the standard anesthetic drugs, muscle relaxants, etc., I would say you can either go for the second generation. Shortly there are already prototypes of third generation devices. They might be as good as endotracheal tubes, which we are all comfortable with. So let's go home and try to digest whatever they have presented and see if we can maybe alter our practice for the better in at least a few cases. So at the end of the day, it's a pro-con session. So let's take a vote on what we are carrying home today. So how many of you have used endotracheal tubes for laparoscopic surgery under general anesthesia? A show of hands, please. Right. So more than 90%. How many of you have used laryngeal mask airway devices for laparoscopic surgery under general anesthesia? Starting with Pankaj sir, so quite a few of you, maybe around 10%. Now, as a result of the discussion today, how many of you will think of using a supraglottic airway device for laparoscopic surgery? So, half of you, right? So, with that, wishing you all the best, but always ensure, patient safety, ensure that the stomach is empty. Right now, medico-legally, we are bound to look at the gastric content in all the pre-op patients with an ultrasound. Even that is no guarantee that we can still protect from aspiration, but that would be my biggest care. Thank you all for the patient hearing. We are also open for any audience opinions or questions.
Going to face the exam, and none of the examiners will agree if they say that I'll be using
Absolutely.
A supraglottic airway device for laparoscopic surgery.
Thank you very much, GURUDATT sir, for that reminder. At this point, I will also say this: if I were a patient for a laparoscopic surgery tomorrow, what device would I prefer to be put in me? Would it be an endotracheal tube or a supraglottic airway device? So, thought for. That's food for thought.
And most of the textbooks also say that it is better not to use a supraglottic airway device for laparoscopic surgeries, because it is not there in the textbooks. I think the students also have to tell the same thing. Though of course debate is always a debate, but one has to be careful in answering in the exams.
Now you have seen from the statistics that Western countries, they are more and more moving to supraglottic airway devices for most surgeries, but whether medico-legally it will ever be accepted in India, when the textbook says that the gold standard is an ET tube, ultimately we have to think of being safe legally as well. So that's another thought.
So, as a practitioner, legally we can practice this. What's your opinions?
I'll also go with the collective senior opinion from here.
Sir, just one comment. The thing is that we cannot blanketly say that this is good and this is bad. See, it is all customized to each individual patient. If your seal is good, you don't have any leaks, and you know that it's able to sustain a pressure, and you have put in an LMA or a second generation LMA, maybe you can go through it. But at times, if it is not well placed, if there is some audible leak, continuing with that device may compromise the safety of the patient. So those things have to be kept in mind. It's not one for all rule. A lot of troubleshooting is involved, and it also has a lot of interpersonal variations, how you manage an LMA or a supraglottic device. I may manage it very differently than what you could do it. So the experience makes a lot of difference, how you troubleshoot a particular place when you are having problems. If you have a difficult airway, maybe that's a good choice to use a supraglottic airway device, because managing a difficult airway becomes another issue. So there are issues about it, and I would take with a pinch of salt to give vote to each one of them. I would rather look at the patient and then decide what is the best for each patient which we anesthetize.
So it might also, call for a change in practice gradually from the usual kind of general anesthesia we give to a TIVA or a balanced anesthesia. That's one. And then, interestingly, for the young people here, 10 years ago or 15 years ago, we had a lot of LMAs available. We were using it quite a lot. It was a novelty as well. But somehow it seems to be going out of our armamentarium again, and the IGELs have largely supplanted the second generation devices, which is not a good thing. You need to be well versed in everything, so please use the LMAs that you have available in the OR along with your faculty to supervise. You were talking about Pro Seals a lot. What is the cost of a Pro Seal LMA right now? Or a fast track? Any idea? Yeah, so it's about 30,000. Okay. So ask your managers to get it for you, and you can hear the responses. I have put ProSeals and fast tracks on my department budget for the last 2 years. They've still not materialized. So that's again where we are.
Thank you. Thank you, speakers and moderators. I would like to call upon Dr. GURUDATT onto the stage, and Dr. Anita to felicitate Dr. GURUDATT, Dr. Lakshmi, and Dr. Sumesh.